Okay, so you're here to see Dr. Lynn, Dr. Harrison Lynn from UCI Health Center, Department of Otolaryngology. Now that's a big word for you. And he's going to be talking about hearing loss and dementia. He's going to be talking about the connection. He's also going to fill you in on some other topics. I'll get it for you. So he's an assistant professor at UCI Department of Head and Neck Surgery, it's otology, neurotology, and skull-based surgery. Whew. He does it all. So, but I have a question to ask you. If somebody had, for example, an ear infection, could they make an appointment to see you?
Absolutely, absolutely. Anything regarding the ears, the ears.
Okay. Or if they had too much wax and they needed to have it removed?
I do that too, yes.
Excellent. So he does the ordinary things too?
Yes.
Okay. Let me get your PowerPoint for you.
Thank you very much. Thank you very much. Thank you, Tony. Thanks for the kind invitation once again. This is always a lot of fun to come out here and talk. I usually give like maybe half an hour or so talk, and then usually there's a lot of questions afterwards. I'm happy to try to get to all of them, because I know it's a very important thing to everyone. Hearing is how we connect. Is one of very few ways we connect with the world, and if your hearing is compromised for one reason or another, it can be isolating. It can be frustrating. Fortunately, there are a lot of good options out there, and moreover, a lot of great reasons why you should try to rehabilitate your hearing. Try to make sure you connect with the world, connect with your friends, connect with your family as much as you can, because we've known for decades that it's good for your brain health. As you've probably all heard it before, you use it or lose it when it comes to your brain. It certainly seems to apply with regards to hearing. Not only if you don't rehabilitate your hearing seems to diminish at a greater rate, but moreover, by rehabilitating your hearing loss, your brain just works longer. It exercises the brain, and I'm going to go over a lot of data. It might be a little bit complicated, but I think it's important for you to kind of understand the research studies that are out there, so that you understand the importance of getting your hearing up and running and interacting with people, maintaining your social circles and staying active, because it's going to pay off in the long run. Okay, so we're talking about hearing loss and dementia, and I'm going to talk basically a little bit about the epidemiology of hearing loss and the connections. I'm just going to go over basically a handful of papers and review the data. Basically, everything agrees with each other. There's a lot of evidence that shows that uncorrected hearing loss that you have but don't do anything about, compared to someone who does do something about it, you're really putting a toll on your brain. A little bit higher. Excellent. And then, just so you're all familiar, when you do go, if you're, hopefully this talk gets you interested in your hearing health, and if you've never had a hearing test, or you've had multiple hearing tests and just follow along and don't really understand what's going on, it's a good idea to understand the severity of your hearing loss, and so potentially to know, what the next steps would be if it gets to a point where hearing aids aren't helpful. So we'll go over a little bit about the hearing tests and then hearing loss solutions. Hearing loss is very common, as we all know. It's the third most common physical ailment after arthritis and heart disease. At least 15 to 20% of adults have them, and when you get up to over age 65, 1 in 3. And then a lot of children are born deaf as well. We won't get into that great deal of detail. The good news is, as I mentioned, most of the times, hearing loss is addressable, through one way or another, either through hearing aids or through cochlear implants, and we're going to go into that in a lot of detail. So before we get into hearing loss and ways to address the hearing loss, let's talk a little bit about why you should care. and why it's good for you to consider hearing aids, or if hearing aids aren't of benefit, your hearing is too far out to have hearing aids be of help to you, a cochlear implant. So we've known for a long time, and you may have come across these on your newspapers and in your these titles, headlines in your newspapers and in your online searching, that basically hearing loss is clearly a risk factor for dementia. This was the last one was in the AARP website, and these are in response to just countless number of papers that keep coming out based on high level of evidence on population-based studies, looking at hundreds, if not thousands, of people and comparing people, directly people with hearing loss, and then they get it corrected, and then their eventual rates of Alzheimer's and anxiety, depression. Very, very good papers that we should all pay close attention to. So I did a little bit of a summary in here. Hopefully you can see it comes out a little bit small, but I think it's important for us to just get at least a little baseline understanding of what you're risking if you don't go forward with hearing rehabilitation. So longitudinal studies of community-dwelling older adults have demonstrated that hearing impairment is independently associated with a 30 to 40% rate of accelerated cognitive decline in both auditory and non-auditory cognitive tests. So tests of your cognition and mental abilities, both with and without auditory cues, and substantially increased risk of incident all-cause dementia. So looking at all different types of dementia, vascular dementia, Alzheimer's, basically looking at any sort of dementia diagnosis, you're going to have an increased risk of that if you have hearing impairments. And that is what we call kind of a dose-dependent relationship. So if you have a mild hearing loss, you're twice as likely to develop all-cause dementia. Moderate hearing loss, 3 times. Severe hearing loss, 5 times. And so that really emphasizes the close relationship between hearing loss, uncorrected hearing loss specifically, and your mental and psychological health. Moreover, neuroimaging studies have demonstrated independent associations with hearing impairment with reduced cortical volumes in the auditory cortex and accelerated rates of lateral temporal lobe and whole brain atrophy. So that's a lot of complicated words to basically tell you that people with hearing loss that are uncorrected basically have smaller brains. Their brains do actually, on MRI imaging, grow smaller compared to those who have hearing loss and have the hearing loss corrected. So, what's that?
We have hearing aids.
Yep, exactly. Where the rate in which, everyone's brain gets smaller as we all get older, but those who have corrected, who wear the hearing aids, that rate is smaller, and that seems to be very, very clear in a number of studies. This is a study that came out last year that looked at 36, combined the data of 36 different studies, and basically showed specifically age-related hearing loss. So high-frequency hearing loss, we're going to get into that and a little bit some more as well, was independently associated with increased risk of cognitive impairment and dementia. So twice as likely, those with hearing loss that are uncorrected, twice as likely to have cognitive impairment, and over twice as likely to have the diagnosis of dementia. And they went into this, and this is kind of also kind of widely accepted and understood, the reasons for the cognitive decline with hearing loss. And it's summarized here. Basically, age-related hearing loss can result in limited communication and consequent social isolation and loneliness and depression. And this may add to the cognitive load of an already vulnerable brain, because as we all get older, our brains have a lot of other neurochemical changes. And if you have social isolation, anxiety, depression, this can lead to additional changes in the brain, can lead to social disengagement if you can't hear, You can't talk to your, like Tony was saying, you stop going to church, you stop going to your bridge club or your other social activities because you can't hear. That just leads to this downward spiral of cognitive decline and just brain decline. Like I said, again, I'm going to repeat it over and over again. You use it or lose it. You have to stay active to get your brain, you have to keep your brain active to keep your brain kind of exercised, and part of that is making sure you engage socially and have a lot of intelligent, in-depth conversations and interact with your friends and family. This paper here by one of our ENT colleagues at Johns Hopkins basically was kind of let the world know that we've known about this since like probably the 1950s and 1960s. And his question is, who's listening? I mean, there's such an important opportunity here to try to reduce the rates of dementia amongst all of our older population. And it's one of very, very few modifiable risk factors, and yet there's impediments to getting hearing aids. There's impediments to getting hearing tests, even from Medicare. And so that's something that we should all pay attention to. We did the study in response to this paper, looking at what primary care physicians do once you tell them about your hearing loss. And then we found that over 1 in 5 people carrying the diagnosis of hearing loss on their medical records have never had a hearing test. And so it's important. It's important for physicians like me to try to spread the word, to make sure that to emphasize to you all and to my fellow physicians that hearing loss is very, very important to address. It's very easily addressable, and there should be very, very, very little impediment to getting a hearing test, potentially a hearing aid, and then, if needed, a cochlear implant. This was actually a paper that came out probably 2 or 3 weeks ago that made a lot of the lay press. This was one of the stronger studies that showed that people who have hearing loss and use hearing aids keep themselves healthier. Basically looking at over 100,000 adults age 66 years or older, all of them have hearing loss. And they compared the group of people of this 100,000 plus who did use hearing aids compared to those who didn't use hearing aids, and looked at how long it took before they developed a diagnosis of Alzheimer's. How long did it take before they, on their medical records, showed up with a diagnosis of anxiety? And so their conclusion was the use of hearing aids is associated with a delayed diagnosis of Alzheimer's disease, dementia, depression, anxiety, and injurious falls among this study group. So basically, a lot of people do end up getting some of these diagnoses, but those who used hearing aids, it took longer to get there. So basically, by using hearing aids, you're delaying, you're hopefully enjoying more of your life without these diagnoses. Okay, so I'm going to move on to, I think probably reserve questions for last. I'm going to move on to a little bit of your potential. I'm sure many of you have already been to an audiologist, but if you haven't, here's some information about what you would experience when you're there. So basically, when you go to an audiologist, you're there to get an audiogram, what we consider the EKG of the ear. And it's a very, very specific and sensitive test. It's hard to cheat on it. It's a very, very good test with what we call very small test-retest variability. It'll test what you hear and very, very well, and do it very well. So basically, the subject goes into a soundproof chamber, and then the audiologist either speaks or plays words on computers, words or tones on the computers, and they play one ear at a time to measure both your left and right hearing. And there are generally 3 components to a hearing test, and we'll get into depth on only 2 of them. First is audiometry. This is when the audiologist plays tones in one ear at a time at escalating volumes, and then you either raise your hand or push a button to tell the audiologist when you hear that. They play that across a number of frequencies that are important for communication, and that comes out in a graphical form, which we'll go over shortly. Actually, we'll go over that right now. So this is kind of an example of a common hearing test for someone who has hearing loss of aging. So the way you look at this is from left to right are the different frequencies of the tones that were played in your ear, starting from low tones on the left, and then high tones on the right. As you go down the y-axis, these are the escalating levels of the tones that needed to be played in your ear before you push the button. So say, for instance, if it took 100 decibel sound before you heard that, it took a jackhammer going off next to your ear before you heard that, that's bad. Okay, so the lower this curve is, the worse. The lower the curve is, the worse the hearing, the higher the better. And you can see here normal hearing is 20 decibels and above. And then if it goes a little bit lower, it's mild hearing loss, moderate hearing loss, severe hearing loss, and all the way down here to profound hearing loss. Typically, the right ear is in red circles, and the left ear is in blue X's. So this is the audiometry. This is your ability to recognize the presence of sound. So that's the first test that they typically do. And the second test is to look at your speech discrimination score or word recognition score, which is important because hearing you have to, in order to hear, you not only have to appreciate the sound, but enough data, enough clarity has to get to your brain for you to interpret the sound. So if I keep saying the cat sat on the hat, but you hear the fat sat on the pat, and that's not going to make any sense to you. If you're hearing words but it's not clear enough for you, that's also very important to know. And so that's measured in the SDS, or the speech discrimination score, in which you're basically just given about 25 words, 1 ear at a time, at a level well above what you can hear. So if your average score is around 30, they'll play it at 70 decibels. So it's not an issue of whether or not you can acquire the sound. You can definitely hear the word being said, but then if you can't repeat it correctly or mishear it, if they say baseball and you can't understand that the audiologist is saying baseball, then the answer is wrong. And so these scores are kind of like grades. 90 or above is an A, 80 or above is a B, and so on and so forth. And so if you get 70 or 80% of the words correctly, ideally 100%, but if you're 70 or 80, it's passing. You can understand what's being said, and especially with context and understanding and knowing the person's voice, it's usually passing. But if it gets down to 50s or 60s and you're even below, then if you're missing over 1 in every 2 words, then that could be a problem. And we'll talk a little bit about what we can do about that. So that's the speech discrimination score. We're not going to go into pentagrams. We're not going to go into much depth about the types of hearing loss. For the most people in this room have sensorineural hearing loss, or just plain and simple nerve hearing loss, and not a conductive hearing loss, in which you have something wrong with your eardrum or hearing bones. So a little bit about nerve hearing loss. It's often permanent in that without surgery, there's not much you can do. It's just your nerves are no longer kind of responding the way it used to, and that comes with age. That comes if you have a lot of noise exposure in the past, the military, or a lot of concerts, and then if you've had some trauma to the head in the past. There's some other reasons for nerve hearing loss that are less common. So probably for most people in this room, the most common cause of sensorineural hearing loss, or type of sensorineural hearing loss, is age-related hearing loss, or presbycusis. And so typically, like I said, it's a high-frequency hearing loss, in which basically it takes a lot more energy for you to appreciate high-frequency sounds. Whereas in low frequencies, for instance, my voice is probably around 500 to 750 hertz. Probably, hopefully, most of you will have less difficulty with my voice. Age-related hearing loss is a slow, gradual process for the most part, and because you have if you did have presbycusis and you have high frequency hearing loss, oftentimes it's actually most difficult for you to understand or follow a conversation when you're in a restaurant or a noisy environment. Some of you may relate to that. And that's because when you're in a noisy restaurant, a noisy environment, a cafeteria or something, the background rumble tends to be a low frequency rumble, which then masks away the low frequency aspects of the speaker's voice. And you have to rely on your higher frequency hearing in order to hear what's being said. And if your high frequency hearing is poor, then it can be very troublesome and can be very difficult. And can be, like it's mentioned here, can be isolating and depressing. But the good news is typically it can be addressed with hearing aids. So yeah, particularly for people, as I mentioned before, with high speech discrimination scores or word recognition scores, if your problem only is with sound acquisition, and once you hear the sound, once there's enough energy getting to your eardrum for you to hear the sound, and you're getting 4 to 5 out of 5 right, then clarity is not an issue. The hearing aids are going to be of tremendous benefit to you. And just a brief word on hearing aids. I don't do hearing aids, but many of you ask, or I get a lot of my patients ask, does it have to be in the ear? Does it, what does it look like? Is it really obvious? And for the most part, for this talk, basically, you just, I guess you just need to be aware that there are various types of hearing aids. Generally, the worse you're hearing, the larger the device it has to be because you need more power. And generally, the smaller the device, the more miniaturized you want the device, it's going to be a little bit more expensive. And if you want a smaller device, it's just something that you may have to pay a little bit of premium for. And so how do hearing aids work, and why are they so expensive? They're $1,500 to sometimes $3,000 each, not because they can charge you for that because they want to charge you that, but it's because it's sophisticated, technology. A lot of us have iPhones and smartphones, and no longer having the dial-up phones and pay $1,000 for them because they're helpful and they're sophisticated device made by high quality companies. And so the advantage of a hearing aid, what's the benefit of a hearing aid, is that it can basically take a sound that enters its microphone, instantly determine what frequency that sound is, and then give it frequency-specific boosts for where you need hearing, where you need help, programmed by your audiologist. So, for instance, if some of you here are wearing hearing aids, but have very, very good hearing at 500 hertz, my voice is going into that hearing aid and coming out at the same volume that it went in, because many of you, those of you who are wearing hearing aids, probably have pretty good 500 hertz hearing, lower frequency sounds, and don't need the amplification. But let's say a little girl came up here, or there's a mouse squeaking somewhere, hopefully not, then that sort of high frequency sounds does need help. And that sound, which if you weren't wearing the hearing aid, you wouldn't hear, but then if it gets to the hearing aid microphone, then gets boosted, let's say it's a 4,000 hertz sound, gets boosted 50, 60 decibels until you can hear it. So it's played into your ear at 50 or 60 decibels, but you hear it as if you heard it at 20 decibels, back maybe 20 or 30 years ago when your hearing was better. And so that's the advantage of hearing aids, is that very sophisticated, compared to your over-the-counter Walmart sound amplifier for $69 that just basically amplifies all frequencies. The hearing aids that you buy for in excess of $1,000 has this technology, has this sophistication to take sounds, amplify them appropriately to your hearing loss, to your hearing tests. Okay, so that's the story about with hearing aids, and very, very helpful. The majority of people here with hearing loss is probably going to benefit from hearing aids, and probably a far fewer fraction of you would enter the realm of the cochlear implant. But some of you will, and so certainly something that I'm going to talk about. And moreover, the indications for cochlear implants have, as time goes on, get broader and broader because our technologies get better and better, and our confidence that our cochlear implantation will be far better. You'll come out on the other end after the surgery far better than when you went in, at a very, very high rate, high frequency of success, that our threshold to put cochlear implants into individuals with hearing loss is getting lower and lower. And so we'll talk a little bit about that. So as I mentioned before, majority of people here with hopefully high speech discrimination scores in the 80s will do just fine with hearing aids. You don't even qualify for cochlear implant, but you're probably going to be very, very happy with your hearing aids. But for those of you with low speech discrimination scores, so let's say you're at 36 to 44%, so 7 out of 10 words you mishear. Only 3 out of every 10 words coming out of my mouth you actually hear. So in those cases, hearing aids aren't going to be helpful, because even it's not an issue with you hearing, because you can hear the words, but if it's all kind of mumbo jumbo and you're not capturing the right word the majority of the time, then it's going to be very, very difficult to follow the conversation. So those of you with low speech discrimination scores thus fall into the cochlear implant candidacy group. So a little bit about cochlear implant. It's considered the most successful neural implant in human history. Over 1 million of them have been put into people worldwide. Basically, a cochlear implant is a nerve stimulator. It's a small nerve stimulator that gets put into your cochlea, into your hearing organ, and then stimulates your hearing nerve in 16 to 24 different locations to give you 16 to 24 different frequencies of sounds. And with those, typically, you can understand speech far better than what you could before the surgery. So basically, we use electricity, external kind of battery-driven electricity, to stimulate your hearing nerve to get it to work again. You can see we do them in kids as young as 1 year old. That's what the FDA approves. We're doing them younger and younger because kids who are born deaf, the earlier we implant them, typically on both sides in one surgery, the more likely they'll be mainstreamed and do just as well as their hearing counterparts in school. Kids get them, adults get them, and then the elderly get them as well. The kids and the elderly are our highest, kind of the biggest numbers, and our most frequent patients. And so implant, we'll go into a little detail here, a few pictures about the implant. Basically, there's the component that I put in, the implant, is here on the left, and the component that you wear outside starting about a month after the surgery, that has the microphone and then the transmitter. I think we'll go into this in detail, and this is how it would look on the inside. Basically, the implant is behind the ear, underneath the skin, and then the array I put into your hearing nerve right here, and then stimulates your hearing nerve. And then your external component communicates with the internal component wirelessly and electromagnetically. I think we have a little bit more on this. Yeah. So again, this is the implant that I put in. Basically, I tuck it behind your ear in a small incision, about 2 inches long, and between your skull and your skin. I think I've been asked the question before, is it brain surgery? No, it's not brain surgery. It's about 2-hour surgery. We'll get into it. Outpatient, you go home the same day. So I tuck this underneath your skin, and then this little array here goes into your cochlea, into your hearing organ, or right by your hearing nerve, to stimulate it in 16 to 24 different locations. And then a month later, you get this device that has the microphone and speech processor, so sounds go into here along with the battery. Sounds go into here, get converted into digital signals, and then based on programming from your audiologist, these signals are then transmitted wirelessly. This is a magnet that connects these two. Signals go through your skin to this device, and it tells the array to stimulate appropriately. This is another way of looking at it. The implant, the gray is the implant that I put in, and then the darker color, the darker brown here is the the external part with the microphone and the transmitter to communicate with the implant that I put in there. And so the nerve, the hearing nerve itself, it runs, this is the organ, the hearing nerve runs right down the middle of it. And so it's very convenient for me to put this array with a number of different electrodes to simulate a number of different bands or different bundles of your hearing nerve. This is the criteria for adults, children, and infants. It's basically you need to have severe to profound nerve hearing loss, and generally speaking, word recognition scores of 50% or below in both ears. You need, if you have that on your standard hearing test, you then need to have a formal cochlear implant test in which you have to repeat sentences correctly, and if you fail that, then you become a cochlear implant candidate. So the surgery itself, I know it sounds scary, and surgery overall is a scary enterprise. I know a lot of you are probably worried about your heart and your lungs and having a stroke or heart attack during the surgery. Yes, that's something that we're always worried about, but for the most part, it's we always basically do all our homework. If here at UCI, basically if you're generally about 70 or older, with or without a heart history, we do kind of insist that you see a cardiologist to at least get an EKG, if not an echocardiogram, just to make sure that the stress of the surgery, the anesthesia, which is actually your greater risk with this surgery, is going to come out okay because you go through an echocardiogram, a stress echocardiogram, and your heart does just fine. So my part is basically a 2 to 3 hour surgery in general anesthesia, small incision behind the ear, no stitches to remove. You go home the same day. You typically need some narcotic pain medications for 3 or 4 days. And then after that, Tylenol should take care of the pain. I see you again 3 weeks after the surgery, and pretty much after that, you're done with me, and you're in the hands of one of our cochlear implant audiologists who gives you the external device at 4 to 6 weeks after the surgery, and then kind of takes you through what one of the companies calls your hearing journey. So it's sometimes immediately you hear a lot better. Other times it takes a little bit of time to have a good quality sounds. Risks with the surgery are all very, very small. It's just something that statistically speaking, they say that you're actually more likely to be hurt in a car accident on the way to the surgery than actually be hurt during the surgery itself. It's just something that obviously if you're in that group, we would talk about, but for the most part, all these risks are far less than 1 in 1,000 to 1 in 10,000 chances. There are 3 different companies that you get to choose from for the most part. Some of them come with different, basically what I call toys, things that connect directly to your iPhone or connect directly to your phone, Bluetooth capabilities, waterproof capabilities if you want to wear them when you're swimming. And so each company offers a little bit of different little extras, but for the most part, the outcomes are all the same. And I actually don't think I think what I neglected to put in here was the outcomes. Generally speaking, as I mentioned, you get one of these implants when your speech discrimination scores are 30 to 40 or 50% or lower. In our institution and across the nation, for the most part, on average, people get to 75 to 85% speech understanding scores after the surgery. So you go from 30 to 40 all the way to 75 to 80 to 85. And then your thresholds to hear basically also, for the most part, normalize. So you'll need to wear another hearing aid to work with the cochlear implant. You can hear me the way I'm talking at this volume without, with your cochlear device. So the thresholds for you to hear are good, and the clarity is also very good. Some people ask about music and about more finer sounds. At this point, music appreciation isn't a selling point for the cochlear implant, but for sure, conversation, speaking, especially in English compared to other tonal languages, does a great job. Does a fantastic job, and it really changes a lot of people's lives. And I mentioned the last thing, and this is the last slide here. I mentioned how basically the thresholds, or basically the criteria, are liberalizing as we get more kind of more and more advanced technology among the cochlear implant companies. So 2 of the cochlear implant companies now have what's called a hybrid cochlear implant, in which people with bad hearing, but not too bad, but bad hearing in which basically their high frequency hearing is basically in the tank. There's no hearing in the high frequencies, but pretty decent hearing in the low frequencies. And then one ear is worse than the other, and it's just very, very difficult to communicate. Both ears are bad, but one's really, really bad. We can put in what's called the hybrid. It's a combination of a cochlear implant and hearing aid. So when I put in the cochlear implant, I only put it in a smaller array about halfway up your cochlea so that you hear electrically for the high frequencies, but for the low frequencies, you hear through your natural ways, through your ear canal, with the assistance of a hearing aid. So basically, it opens up the door for cochlear implant candidates with not that bad of a hearing, but hearing bad enough that they're still frustrated by their hearing aids. So that's something that's now offered for two of the cochlear implant companies. And I think that's about it. I kept this short kind of on purpose because I know there's usually a lot of questions, and if Tony agrees, this is a good time to have the questions, or she's on her way. Thank you very much. Oh, okay, great.
Yeah, Dr. Lin, you had one slide there. You had one slide there that showed that use of hearing aids delays the detection of
The diagnosis.
dementia. That's wrong. You're implying there that use of hearing aids delays the detection.
Detection or diagnosis, true.
Which is, so you're suggesting we should not get hearing aids?
No. It's the diagnosis, and so it basically, with all other factors, age, degree of hearing loss, all taken into account, people who use hearing aids go about their lives. They go to see the doctors. They're fine. I'll just pull numbers out of my pocket. It takes, for someone with hearing loss, let's say they don't get it corrected, they'll have dementia symptoms. They'll have Alzheimer's symptoms. They'll have anxiety at 2 years after the diagnosis of hearing loss without the use of hearing aids. But people who have hearing loss, who wear hearing aids, they won't get that diagnosis until 10 years. That's a little bit exaggeration, but there's a relationship there that shows that the people who are community dwelling, they go to their doctors, and the doctors are not diagnosing anxiety, they're not diagnosing dementia, they're not diagnosing depression until far later than those who don't use hearing aids.
One more question. You said you have atrophy of the brain related to hearing loss. Is that primarily because people kind of become themselves, they stay away from other things?
That's the theory. That is the theory that those with hearing loss, if they start disengaging socially, becoming socially isolated, they don't use it, they become hermits, and their brains start to shrink.
And one last thing. Having hearing aids early is better?
Generally speaking, there are people who feel that if you keep those hearing pipes active, you're gonna keep them active, and they're gonna be happier. I'm not sure that evidence is
Thank you.
Yeah, is strong. Yeah.
So Dr. Lin, in lay terms, this is what I tell people, and you tell me if I'm right, or correct me if I'm wrong. So if you have a hearing loss, certain signals are not getting to the central part of the brain that interprets the sound. And so it's possible that if it's not activated, if you're not using that, it will atrophy. the longer you delay getting hearing aids, and if you wind up with permanent atrophy, they say that it's 7 years when somebody's been diagnosed with hearing loss before they get a hearing aid. 7 years. That's what the Hearing Loss Association of America says in studies. That's a long time to go, leaving the hearing center of the brain not hearing. So it could cause detrimental damage. Now, if you have dementia starting and you have hearing loss, it just seems like that's a rapid decline. Is that true?
Well, there's a relationship. I think everyone feels that there's a relationship, and what I tell my patients with and without dementia is that if you're my uncle or my father and you have hearing loss to a certain extent, I mean, a lot of people come in, their hearing loss is very mild, and yeah, there's no problem not getting hearing aids if they're not struggling with their hearing. But if they have substantial hearing loss and their wives or their husbands or their daughters or their sons are frustrated, and dad just won't get a hearing aid. He just doesn't care, doesn't want to, he can't hear. We're shouting at him and he doesn't hear. He just refuses to get a hearing aid. And of course, it's your right not to get a hearing aid. But I guess what I tell my patients is, if you're my dad and I'm in your son's or daughter's situation, I would be all over you to get you to wear hearing aids, because that's going to improve your mental and psychological health. It's one of the very few things you can do to keep dementia away. One of the very, very few what we call modifiable risk factors for dementia, addressing your hearing loss.
So what comes to mind is a saying that can be used in many areas: use it or lose it.
Yes, yes. And that's
So
very,
if you
very
go,
apparent.
if you go
in
too
hearing
long
loss.
without activating that part of the brain, you are at risk for causing damage. And
Yes.
and you can't rehab that you've lost.
Well, you can, I mean,
You can
like I
try.
said, it's just, you can try, and just for us, the way we think about it, it's never too late. I mean, we have plenty of patients who have mild dementia, and the families are very concerned. They can't hear, the hearing aids don't work. And yeah, if they were my father with that same situation, I would get implants, cochlear implants in them. So they hear again, they interact again, and that's proven to slow those scary processes.
Okay, we got a question over here.
So I wanted to sort of follow up on your question, or what you were saying. I'm trying to understand. So let's say you have two different people. One of them is able to watch TV, and they're sitting in their home watching TV for basically all their waking hours. The TV's turned up high enough. They're getting the stimulation, the audio stimulation. So the nerves they're using it, okay? Then there's another person who doesn't watch any TV, but they have their hearing aid, and they go out for 2 hours a day, and they socially interact, okay? Only 2 hours though. So the 2 hours of social interaction versus 16 hours of passively listening to TV, which of those two people is more likely to get dementia?
I mean, those are very specifics. There's a lot of specifics here. I mean, basically, what's the most important message is you can't just take two individuals and try to compare the two. Population-based studies are the most kind of the highest level of evidence, other than randomized, prospective studies. But the best we can do is that basically those who wear hearing aids, and those will include very social people, and those who just sit in the rooms watching TV all day, versus those who don't wear hearing aids also can be very social, or those who are watching TV every day. That level of evidence is far greater than my answer to your question, which I guess I would say, if you're really engaged in the 16 hours of TV and you're watching Ken Burns documentaries and really getting into it and exercising your brain, then that's great. What it comes down to is exercising your brain, working and just thinking, and not just sitting there, not processing, not thinking, not having a lot of cognitive challenges. If 2 hours of going to the coffee shop and just really debating politics and really getting into it versus just sitting around talking about soap operas, that could be that's a difference there too. So the specifics aren't as critical as the overall longitudinal population-based studies based on hundreds of thousands of patients, those with hearing aids, those without. Very, very crystal clear evidence that shows that those with just mentally do better. Yes.
Yeah, just if you are not wearing hearing aids and you have the TV on and it's probably higher than it should be, and you look at an audiogram of many people, there's still parts of the brain that are not being stimulated because of those hair cells. So you're just blasting sound through the system, but it's still in some decibels, some ranges, not, thank you, you're not exercising that brain. I also want to say, a lot of people tell me, oh, they don't wear their hearing aids at home. Why do I have to hear the hearing aids at home? Well, first of all, you need to keep training and the brain, keep getting those sounds up there, but also you need the environmental sounds. You need to hear when the timer goes off, the microwave goes off, when the water is running. I've had problems with my toilet, so it'll run. And if I'm not wearing my hearing aids, I don't hear that water running. So there's a lot of reasons. People knocking on your door, it's a safety issue. If you've got your hearing aids, put them on in the morning and take them off before you go to bed. So we have another question right over here. Oh, wait for the microphone, it's coming. Here we go. Thank you. Is it on? Here, take this.
We all know that loud noises do damage the ears. The hearing aid magnifies noises. I'll be in a crowd and somebody next door to me might yell at somebody and I want to go right through the wall. Doesn't that damage the ears further?
That's a good question. So in humans, it actually does take a considerable amount of noise trauma to cause measurable hearing loss. Even many of you probably here have been to a lot of concerts and been exposed to a lot of loud noises, but actually noise-induced hearing loss isn't that frequent compared to, or that common compared to age-related hearing loss. Yes, there's the hypothetical risk of damage from that person shouting in your ear, but in exchange for 24 hours, 59 minutes, and 59 seconds of otherwise better hearing, I think it's worth it. As long as you're not, it's not constant. And yes, people say, well, you're playing a really loud noise in my ear. Isn't that damage? But no, it's not damage because you have hearing loss. And so that's what if you have hearing loss at 60 decibels, it takes 60 decibels for you to hear at a certain frequency. And I play a sound for you at that frequency at 50 decibels. That'd be really loud to me. But perhaps to you, if it takes 60 decibels for you to hear, you wouldn't even hear that 50 decibel sound. So there's no damage being done there. Nothing's actually being activated, unfortunately. And then so what the audiologist's job is to program it so that just enough energy gets to your ears, gets to your brain, so that you can hear at a normal volume. Yes, it's playing in your ear at 70 decibels, but you perceive it at 20 or 15 decibels at a comfortable level.
Dr. Lin, I've been wearing hearing aids for 30 years.
Good for you.
And at the beginning, I only was given one for a number of years. I've never been vain about wearing them, and I'm very proud to say that I have a wonderful audiologist, and I wear them like 12 to 14 hours a day.
Good for you.
But my big problem I have is with young people like you.
Sorry
whistling,
to
that's
be a
okay.
problem.
Sometimes you speak too rapidly
Oh, did I speak too rapidly?
at the beginning.
I did at the beginning. I usually. Okay, sorry about that.
And
Yes.
my son and my grandson, I have to ask them to repeat what they say all the time because it's just the way you all talk now. But thank you.
Sure, yeah, yes, no problem.
Anybody else have a question?
When you're in this room and hearing accessibility is poor, for any reason, you must raise your hand. You must advocate for yourself. You must raise your hand and say, could you speak a little slower? Tony, you're talking too loud. Whatever it is, or I'd like to borrow a hearing device. This is the one place where we want you to get everything you can. So please, feel free to do that. Just be polite, raise your hand, let us know that you're having challenges hearing in the room. So who else had a question? I think, okay, we got a couple more. Anne?
Ask them.
Oh, she's got,
Here, hold on. Okay.
right down here.
Hi. Oh, so Dr. Lin, thank you so much for a really informative presentation. I have sort of a chicken and egg question. You've talked a lot about the relationship. I mean, we're talking about hearing loss and dementia. And what about more specifically depression, anxiety, and hearing loss? And mild cognitive impairment, or MCI, you know.
Yeah, I mean, here you can see here, basically in this paper, I think this is the only paper that I present here today that basically looked at all of those. That, you know, maybe not mild cognitive decline, but maybe I'll just repeat here one more time. The use of hearing aids is associated with delayed diagnosis of Alzheimer's disease, dementia of all types, depression, anxiety, and falls. So that, I think that hopefully addresses your question. It's your mental and psychiatric and psychological health, all very much intertwined, and generally speaking, the more you use your brain, the more you interact socially, the better your mood and your mental capabilities will be maintained. Yes.
It's my understanding that the hairs cannot regenerate themselves. Is that correct?
That is correct.
And also, I've read that it's not the hair so much anymore. They're considering it's the nerves that are being damaged.
It's a little bit of both. Certainly hair cell counts go down as we all get older, and just to borrow your analogy, chicken or egg, most people feel that once the hair cells go down, the nerve subsequently deteriorates as well. And so, yes, it's both. Fortunately, it doesn't really matter too much which one it is, practically speaking. Your hearing test results are your hearing test results. And based on your hearing test results, you're either a hearing aid candidate or a cochlear implant candidate. And both potentially very, very good options. Yes, downsides to a lot of them. Someone screams in your ear while you're in a crowded environment. Those moments do, you do suffer a little bit, but for the most part, if it's a well-programmed hearing aid, most people do pretty well with them.
Hi.
Hi.
My question is directed to the cochlear implant and how effective it is. I have a problem with total loss in my left ear, so I have a phonex which transmits to my good ear.
Cross ear, yep.
Right, so if I did this cochlear implant, will I be able to hear directly? My problem is not being able to hear someone who's directly on my left.
Very good question. So you have, it's probably a minority of people here, but single-sided deafness. You've lost hearing in just one side, which can be troublesome. You're wearing what's called a cross hearing aid system, a CROS, contralateral routing of sound. So if this is my deaf ear, I have a device that is just a microphone and Bluetooth transmitter. takes sounds from the left side of my world, transmits them wirelessly through Bluetooth to the right hearing aid device that is either a regular, just a microphone, no, a speaker, sorry, a speaker, or if you have hearing loss in the right ear as well, it can also amplify appropriately. So it's called a bicross if it has amplification features. So that is that, along with what's called the bone-anchored hearing aid. Up until probably April of this year, were basically your only two sources of hearing rehabilitation: taking the sounds from your deaf side, and then somehow getting the information to your hearing side. What you're probably interested to know, but it's very, very early, is as of probably April of this year, Med-El, one of the cochlear implant companies based in Austria, got FDA approval for cochlear implantation for single-sided deafness. So prior to that, you basically had to be bilaterally with severe to profound hearing loss before Medicare or any other insurance company would pay for it, at least in the United States. In Europe and Asia, they've been doing single-sided deafness cochlear implantation for quite some time now. The data seems promising that it's very, very helpful to a lot of people, and so hopefully the seal has been broken to hopefully allow that in the U.S. The U.S. is now FDA approved. Your bad ear has to be really bad, like 0 to 5% speech understanding score with profound hearing loss across the board. And then the other potential significant issue is that you've been deaf in that ear for at most 5, maybe, I would say, for over 10 years, the cochlear implant will probably not work. So if this is a recent loss within the past 5 to 10 years, it's probably worth trying. But this goes to show that basically, if you're deaf in one or both ears, and you don't get a cochlear implant 5 to 10 years after, you have no stimulation to the brain, the cochlear implant does not work. And that's because use it or lose it. You don't use it, those pathways deteriorate, and it's hypothesized that the hearing part of the brain gets taken over by other parts of your brain, and so while the signal might get there, there's no neurons there to interpret the sound. So yeah, more evidence towards that effect. Does that answer your question? Okay.
Hold on. No, it's not on.
Thank you for letting me know.
There you go. You're calling.
Dr. Lennon is associate professor. He's an instructor, and he does work with audiologists at UCI Center. For the most part, please don't take advice about hearing aids from your local regional ENT. Meaning, and I'll tell you why. Because I've heard them say, a hearing aid can't help you. That's baloney. The only person that can decide that is an audiologist who does a hearing test and tells you what's up, what's new. So many physicians, they haven't studied hearing aids. They haven't studied hearing loss. And that's just their opinion. What you need is the opinion of a licensed audiologist hearing aid provider. Does that make sense?
Yeah, I think that's
Okay, so Dr. Jillian and Dr. Lynn, those are go-to, listen to them. Everybody else, I don't know so much. Also, listen to Anne. So question here.
Doc, I have 2 questions. One, I have ringing in my ear. Does that mean that is the beginning of hearing loss?
It's sometimes related, and it can be a difficult problem to solve. I didn't get into this very much, but and I feel like sometimes I'm trying to sell hearing aids, and I have no financial interest in trying to get more people to buy hearing aids. But what I can tell you is basically in 2014, our Academy, our largest society of ENT surgeons, a bunch of ear surgeons specifically, like myself, got together and reviewed all the literature about tinnitus, about ringing in the ears. and try to come up with what's called clinical practice guidelines. What should a doctor like me or any ENT doctor advise people about their tinnitus? One of very, very few evidence-based measures to address tinnitus. And most people with tinnitus have hearing loss. So I would predict that you probably have some hearing loss already, even if you don't really appreciate it. Perhaps some high frequency hearing loss, maybe not mild, just a mild and moderate level. And it would be actually in your interest if you did have hearing loss, because then we can conclude that the tinnitus is, or at least presume or hope that your tinnitus is the consequence of the hearing loss, in a way analogous to phantom pain. Those, our soldiers who lose an arm or limb, they actually have, a lot of times have pain in the arm or limb they no longer have. That's because there's a diminishment in their stimulation to the brain, and the brain, for some reason or another, manufactures a sensation. We feel that tinnitus is analogous to this. So maybe compared to 20 or 30 years ago, you don't hear as well as you do now. Wait, yes. 20, 30 years ago, you heard better, and now you're capturing only a fraction of your hearing environment. And so as a consequence, the brain's like, hey, this is I'm not getting as much stimulation as I used to, and it manufactures the tinnitus. And that's important because the majority of people, studies have found that probably 60 to 70% of people who have hearing loss and tinnitus, if they were to wear hearing aids, 60 to 70% of people would find a benefit to their hearing aid, their tinnitus symptoms. Yeah. We got some testimonies here. So basically, by restoring the stimulation, it takes your brain back to the 1960s and 1970s, and it's like, woohoo, this is great. This is it's like the Beatles era again, and then the brain turns off the tinnitus, or at least diminishes it, or you notice it less. So in the end, hearing aids for those with hearing loss and tinnitus is by far the strongest evidence-based recommendation.
So this is something that I have to take care of now.
Ideally. I think it's something that you have the opportunity to take care of. First, by getting a hearing test, and if you do have a hearing loss, strongly consider a hearing aid because it's going to help you in countless ways.
So for someone who has some hearing loss in one ear, and he did not want to use his hearing aid all the time at home, but he used to read and to do puzzles, so his brain is working, then he'll be all right? No brain loss, brain atrophy?
I mean, we're getting back to specifics here. Generally speaking, the more the better. So yes, you your Sudoku and you do your puzzles. That's fantastic. I fully think that that's a good idea. But if you can get, in addition to that, get auditory stimulation, your brain's going to be that much more healthy. That's what the evidence seems to show.
We are going to have to close.
Oh, okay.
Can you stay a few minutes
Sure.
for anybody that
Sure.
still has a question,
Sure.
and then you can come up. But just a moment. We have something for you here.
Wow.
Okay, so here we go. Look at this.
Thank you very much.
This is an early Christmas present. So lots of goodies here. So you have 3 boys now?
No, I have one
2.
boy, one girl.
1 boy, 1 girl. Okay. So this is, you share with them, or
Yes.
or take it to the office
Yes.
and
My-
share with
yes.
Dr. Jillian and Rachel and
Oh, good.
Dr. Stickney?
Yes.
Okay. So,
Thank you.
okay. Hold on, just don't leave yet. Okay, so I wanted 2 things to tell you. Yes. Yes, he does deserve. I wanted to tell you about, oh my goodness, everything's falling apart. So, okay, everything got lost here. I wanted to tell you about membership, $15 per year per person if you join today. You'll be good through 2020. If you don't become a member and continue to come, it's $3 a guest fee. So it's a good deal. It's a good deal to join. I wanted to tell you about tomorrow's the next meeting is going to be being grateful It's Thanksgiving month. So we're going to be grateful for hearing advances. And we're going to talk about what's new in hearing, hearing aids, software, apps, gadgets, and maybe even give you some gift ideas for someone you love. And the presenter will be Audiology advisor Ann Mundell Noel. So that is November the 12th. It'll be in the Globe. If you've signed up to be on my email list, you'll get a notice about that. And that's it. And we're out of here by 3:30. So if you have a question for Dr. Lin, please come up. And turn in your headsets. They don't work anywhere else. Turn in your name badges. And if you've left a paper cup or something, there's a trash by the door. Please take it with you. Thank you very much.